Tetralogy of fallot. Tetralogy of fallot is the most common cyanotic heart lesion. The cause is typically not known. 4 structural abnormalities. Right ventricular outflow tract stenosis, ventricular septal defect, dextroposition and ventricular septum overriding of the aorta, right ventricular hypertrophy. The basic lesion is antrocephalic malalignment of the outlet septum relative to the muscular septum. This is associated with unequal division of the truncus arteriosus into small pulmonary and large aortic components. The malalignment, together with the secondary hypertrophy of the muscle, form the primary site of obstruction to blood flow in the infundibulum or outflow tract of the right ventricle. Clinical features of tetralogy of fallot. The clinical findings at birth vary with the severity of the pulmonary cyanosis. Cyanosis may not be present at birth. Hypercyanotic episodes with paroxysmal hyperapnea. Approximately 1/3 of patients with tetralogy of fallot begin to have hypoxic spells by 4 or 5 months of age. Few of these infants have minor spells. They are often misdiagnosed as a colic. Putting them on the abdomen with a niches position abort the crying and may make the diagnosis. Physical examination of tetralogy of fallot. Right ventricular systolic heavy along the lower left sternal border, a single loud second heart sound corresponding to the aortic valve closure, rarely a continuous murmur of persistent ductus arteriosus is heard at the upper left sternal border. Radiological findings of tetralogy of fallot. The heart is of normal size and lung fields are poorly vascularized. The right ventricular outflow tract and main pulmonary artery segments are usually hypoplastic. A characteristic shaped nose, current sabot, or boat-shaped heart may be present. The ascending aorta is generally large. The superior vena cava shadow may be displaced to the right. The treatment is ultimately surgical. The neonate with prominent cyanosis prompt infusion of prostaglandin E1 is important to keep the beta ductus arteriosus open. Corrective or palliative surgery is usually performed within 2 to 4 months of birth. Hypercyanotic episodes may be treated by placing the infant on the abdomen in a niches position or holding the infant with legs flexed on the abdomen. Oxygen should be given to lessen the dyspnea. Morphine sulfate is especially effective in terminating a prolonged or severe attack. Early elective surgery is indicated for infant with tetralogy of fallot, with or without pulmonary atresia. even in the absence of the symptoms.